So welcome, everybody. I'm Dr. Alan Brown, past president of the National Lipid Association and professor of cardiovascular medicine at Wake Forest University. And I have my good friend Nihar Desai here, who is vice chair of cardiology at Yale and a lipid specialist extraordinaire. And thank you, Nihar, for joining us today on this podcast.
Oh, it's my pleasure, Alan. Thanks for having me.
So I'm hearing rumors through the grapevine that you were presenting some ideas at the MNLA strategic planning meeting that got a lot of traction and made people think a little bit. And the rumor was it was about population health and implementation. And as an implementation scientist, I want to hear what I missed.
Yeah, well, I think those individuals are probably being a little too kind, but I think we're at this very interesting moment now when it comes to lipids, right? We had a new iteration of the guidelines. The science has continued to evolve. We've got, LDL goals back. We have more and more therapies to try and help our patients achieve those goals. It naturally raises the question of how are we going to do it? Because if we have a bit of humble pie and take a step back, despite all the new therapies that we have gotten onto the market that are now available, LDL control rates have really been flat over the last 5, 7, 10 years. And so the question is, what are we going to do differently going forward that's going to get us the kind of results that our patients deserve, that we all want to partner with them around, that's different than what we've done in the past. And so, I mean, we've had, it was a really lively discussion, as you know, having been in that room many times before. And we were sort of reflecting a bit on the guidelines. And, obviously we got those long anticipated and awaited, kind of 2026 dyslipidemia guidelines, I think really moved us forward in some very, very important ways. I think the theme that I was particularly interested in was this idea of athero being a lifelong disease, that the relationship between LDL and events is really about cumulative LDL exposure. And so that naturally gets us to how early do we start? How are we going to identify disease? And then how are we going to bring therapies to the patients who need them? And that generated some very lively discussion there.
Yeah, I mean, it's an age-old conversation. Just making guidelines and doing dinner programs doesn't change practice. And especially when you've got 30 or 40 people in your waiting room, people tend to regress back to what they've been doing, though they may have the best intentions. And, you and I have talked about this before. When we talk about not achieving guidelines to physicians or any providers, they tend to get very defensive. That's not me. I take good care of patients. And I've often thought about this. It might not be them. It's not just them. There are many steps along the way. Was the drug prescribed? Did the patient pick it up? Was he out of pocket so much that they couldn't take it?
Exactly.
Did their neighbor tell them their liver is going to fall out somewhere halfway between their appointments, and so they stopped taking it? I mean, there are many different steps from the time that you implement therapy till maybe a year later when you recheck everything, where you start to lose patients. And as a consultant, that patient might not be seeing you. They may go back to their primary care, who may not refill the medication, or tell the patient you got to call Dr. Desai's office to get that one refilled, and he doesn't do it. So I think we shouldn't be defensive about this, but as we all are more involved in integrated healthcare systems, and we can no longer tolerate wide variability of care from one patient to the next, we're going to have to find ways to solve it.
Yeah, Alan, I think you're so right on that. And I think on the care delivery side, there's so much that needs to be done. Sort of a systems, mindset. How do you hardwire systems to really deliver best high quality care to every patient every time? And then I will say maybe the other side of the coin is also, how do you create a real sense of public health awareness? How do you engage the wider population around their cardiovascular health, informing them and educating people about lipids and cholesterol? What are the important numbers that they have to know about for their own health and well-being? And how do we partner with them on that sort of health journey? And I think there's some really important work that has to be done on that front as well. I think one of the things that we're seeing now is this sort of rise in concierge type medicine. And so for maybe a relatively small sliver of the population, they are engaged in their healthcare in a very, very different kind of way. I think sometimes it goes to, take some odd twists and turns as you get into the longevity and kind of the Silicon Valley, type, twists or variations on the theme. But I think there is, in part, a renewed interest in people's health. And I think the question is what that's maybe relatively small group of the population is doing is they're engaging in more concierge style medicine, getting advanced testing, getting imaging testing. They're getting prescribed therapies, and they have a deep awareness of their risk and the different things that they can do to try and mitigate that risk. And I think the question for us is, well, I think everyone deserves that kind of patient-centered, really deeply, they're deeply educated about the disease process and that they're making the best decisions for themselves as well. And I think, again, we've got incredible therapies now that on the lipid front to really reduce risk. We've got guidelines that are starting to talk about cumulative LDL, really thinking about lowest for longest being best. How are we going to translate that? How are we actually going to deliver on the promise of what's in the guidelines, of what's in the science, what the science and the Mendelian randomization and the epidemiology has told us for decades? How are we actually going to make good on that for the patients and communities that we are here to serve? And I think that really is what is motivating us.
Yeah, and there are no easy answers, I don't think. And one has to put it in the context of what's happening with healthcare in general, right? And the idea that you could provide concierge medicine for everybody, give everybody a Cadillac.
Yep.
We just can't afford to do that in a world where our costs are going up and reimbursement is going down.
It's going down, yeah.
But we should at least have a Chevrolet for everybody. And what does that look like? I can tell you, having been a service line leader at a large healthcare system, and I know you've been involved in the dynamics at Yale, that the anticipation of what's coming is that we're going to be capitated at some point. So the healthcare system will get X number of dollars per month per patient covered. And if that patient gets sick, that's our problem. That's the healthcare system's problem.
That's right.
So you have to manage the risk instead of from the payer. The provider is going to have to manage that risk. So there'll be compromises on what is optimal care. And I think you made the comment about systems that healthcare systems were going to have to put in place. I remember Greg Fonarow many, many years ago saying that systems turn good doctors into great doctors. And having a system in place where we don't miss people, we don't leave it up to individual judgment, where the healthcare system itself puts something in place to make sure nobody slips through the cracks. And when you're responsible for the costs of everything and also for the quality of care, and people grade you on the quality of care, and also decide whether or not they're even going to work. An insurance company might say, we're not going to even work with your healthcare system unless you check off these following quality boxes and show that you're taking good care of patients. There's a real opportunity there. The X factor now, I think, and I'd love your thoughts on this, is that, many patients maybe have insurance where they go to their local healthcare system, but they can also go across the street to a different healthcare system if they want. And so they may just come in and out of the healthcare system and not be engaged in any type of systematic care. But in the future, they probably won't have those options. If you're insured and your plan uses Yale, you have to go to Yale for everything. And that starts to allow the healthcare system to kind of wrap their arms around patients. So your thoughts on that? I think you're exactly right. I think the future will be one where we are going to push to value-based care. We are going to push to capitation. I think it's maybe the only mechanism that truly will align all the incentives so that the patient's best interest and the provider's best interests, and then the financing model actually all line up. I think transactional fee-for-service, the incentives are very perverse, are very misaligned in some very fundamental ways. And we see that playing out every day in our clinical practices. And so I agree with you. I'm optimistic, frankly, that as we get this push to value, that will more fully align
the interests of patients and providers, and also the financing system. I think one interesting sort of twist on that, and I know you guys have actually been part of the leaders on this, is how do you leverage imaging to start to advance our understanding of this? I mean, I think for too long, we've been tethered to this, frankly, archaic distinction between primary prevention and secondary prevention. And I think the guidelines, though they speak to maybe a new way or maybe a different paradigm going forward, I think still are built on some of that architecture. But really, it's not about primary prevention, secondary prevention. It's about, do you have atherosclerosis or do you not? And what's exciting is we now have imaging technologies that really bring that question into very clear focus, that for a very simple, readily available test, someone can really at least have a binary answer to that very fundamental question of, what is my degree of athero? Do I have it or not? And how does that inform the very fundamental, important decisions I'm going to make about lipid management and trying to reduce my risk of cardiovascular events? We've learned so much from you and the things that you guys have done in your own system and kind of in this area. But I think the audience, might benefit from some of that too, Alan.
Yeah, I think your point is very well taken. I mean, the terms primary and secondary prevention, I'm old enough to remember where they came from. A patient would walk in the office and you had no idea if they had atherosclerosis. So we assumed that everybody with risk factors is going to be in danger of having an event. But until they had an event, they were primary prevention. So we had kind of softer goals for those people. Once they had their heart attack, then we got aggressive. And many times the cat was out of the bag, as you've already alluded to. You really want to treat risk factors early. But then if we took somebody to the cath lab for unusual chest pain and found a 40% lesion, most cardiologists would say that's not primary prevention anymore. That's secondary prevention. But by definition, it's not.
Yeah.
Because the definition of secondary prevention is you've had an event. And that person hasn't had an event yet. So we just don't think in those terms.
That's right.
We don't need those terms. And I totally agree with you that, that the question is, do they have evidence of atherosclerosis or don't they? On the flip side of that, as I always say, not everybody who crosses the street with the red light gets hit by a car. And there are people, maybe up to a third of folks who have multiple risk factors, who for whatever reason never get atherosclerosis. So those people were kind of overusing resources on.
That's right.
And they have an excellent long-term prognosis if they're an adult and they have no evidence of atherosclerosis. We don't have 20-year data, so we have to make a judgment in terms of how aggressive to be with them. But the other 2/3, we find atherosclerosis, and many of them had no idea that they were even at risk. So I think the future of imaging, especially as we start to move away from radiation exposure in imaging, is that we'll probably use that on everybody. And then that'll help us decide, instead of primary, secondary prevention, as you said, do you or don't you have atherosclerosis? And I hope someday we figure out why those people who don't, what magic sauce they have in their system.
Yeah, that's right. And Alan, I think maybe the other piece of this that we have to maybe fold into the discussion is, that distinction between primary and secondary is sort of juxtaposed against the science, which is the relationship between LDL and cardiovascular disease is about cumulative exposure. And so this idea of almost waiting until someone has an event to more aggressively treat them flies completely contrary to the science, which is, hey, this is a lifelong disease. It's about cumulative exposure, that time is very much of the essence, that trying to get a handle on LDL and other very important risk factors, maybe even at earlier stages of life, we know pays very important dividends in terms of, reducing morbidity and mortality from cardiovascular disease. And so I think we are in the midst of a mindset change, of a paradigm shift. And hopefully, as the science continues to evolve, our guidelines will continue to evolve. And then ultimately, we have to translate those guidelines into, care delivery and our clinical operations. And that's obviously, additional hard work that we need everyone to step up for.
Yeah, I think when we talk about primordial prevention or treating patients, really young, everyone goes, "Oh my God, you're not going to put our kids on medications." You don't have to do much as
That's
a
right.
child, right?
That's right.
If you're born with genetic ezetimibe, your NPC 101
Yeah,
protein is mutated, you only get a 17% drop in your LDL, but your lifetime risk goes down by over 80%.
exactly.
So, as they said during the first moon launch, the first landing on the moon, if we miss the angle of our trajectory by the size of a dime, we'll miss the moon by 100,000 miles. And I think, we want to think about little changes early and what a 401k plan that is for your future in terms of giving you a dramatic decrease in having adult cardiovascular events.
I think it's so well said. I think the stakes are really high. The urgency is real. Is real. And I think we've now got the science. We have the therapies to really deliver on the promise of cardiovascular disease prevention for the population at scale. And I think that's the really exciting time that we find ourselves in. There's going to be a lot of work. There's going to be a lot of learning that has to happen on the science, on the delivery side, on the operational side, what financing model is going to, enable all of that to happen, and what institutions are going to step forward and really lead the charge there. But I think it's a very, very exciting time, for lots of reasons.
So let's pivot for a second. I'm sure you lay in bed like I do because we're geeks and think about what would this look like? We, for time immemorial, have been talking about individual physicians going to dinners, learning about science, and thinking they're going to go back to their practice and completely change. And as you pointed out, again, I'm not blaming the doctors, but for whatever reason, whatever the issues are that we discussed before, we haven't made a lot of headway. So the question is, what would a world like that look like? I have gotten a little bit disillusioned with all the things we've been doing in the past, thinking that education changes patient care. It's important, it's critically important, but as you mentioned, systems change it. So we've been looking at having a central core in our healthcare system for those patients that we own, our full risk patients, and that central core is a group of experts. They have a communication approach through other providers. It may not be the patient's primary care provider, but a series of maybe APCs who are out there to help communicate with patients. And that small group of experts manages chronic disease across the whole system. And their job is to make sure there's a uniformity of care to all those patients. Now, there are a lot of problems with that, and we're not there yet. Like even having the patients pick up the phone and not think it's one of those cold calls from an insurance company or something. But that's one approach. I'd love to hear your thoughts on where you see this new world and, how we're going to provide that Chevrolet for everybody.
Yeah. And maybe to be a little more provocative, I think that's a great, example, and, maybe one model that will work. The example that has kept me up at night, maybe as of late, is, do we really think that when on average, a patient who sees their provider once a year for a single 20-minute visit, after they drove 45 minutes to pay $12 to park in the Yale Physicians Building parking lot, to wait 30 minutes in the waiting room for a 20-minute visit with their provider, that's going to deliver cardiovascular disease prevention at scale for the population? Now, invariably, that's a model that works for some people, and people do that every day, and we have the privilege of taking care of those people every day. But there has to be a different paradigm as well. I think the one that you gave is a very important example. I think maybe the one that I'm increasingly interested or thinking about is, how do you leverage maybe retail partners or other sites of care? Who's delivering care? Where is it happening? What digital tools and technologies brought to bear for those kinds of clinical interactions? And I do think we have to envision a future where some of that screening, initiation of therapy, intensification of therapy, implementation of guidelines is not happening within the traditional four walls of the healthcare system, but might be happening in a local pharmacy or in a grocery store or in another site that's community-based, that's frequently visited, has hours that are more accessible, to our patients. And I think we have to think creatively about how health systems will partner with those organizations and retailers to really get involved in healthcare and healthcare optimization.
Yeah, and I think some of the disruptors, the Amazons of the world,
That's right.
et cetera, are already thinking
That's
about
right.
this. The other interesting future is wearables, So I always envisioned a healthcare system where the patient is never discharged. So
That's right.
You got your arms around them throughout their whole life, whether at home or at the grocery store or in your clinic. I think we're going to see fewer and fewer large hospitals they're going to take care of the sickest of the sick.
That's
But
right.
there might be a smaller hernia hospital where all they do is hernias, and they do it perfectly, and they do it at a much cheaper cost because that's all they do. They don't need to have an MRI scanner or PET scanner there. They just need to fix the hernia. And so the more common stuff may get doled out to these smaller places, and then the hospital will be for the people who are the sickest rather than a place to have 40 buildings and a lot of clinics. But I think thinking about wearables, for example, which are coming, that can tell you your PSA is up the minute it's up instead of hoping to pick it up once a year, and possibly other parameters, your lipids, your electrolytes, everything, where someone looking at a dashboard can say, it's Tuesday, you don't have an appointment, but I see you have a problem. And I think that's coming, actually. I don't think it's tomorrow, but I think probably within the next couple of decades, we're going to see people with wearables and chronic monitoring just on their day-to-day life.
Yeah,
I don't know.
I think you're quite right. And as much maybe trepidation as we have, for that kind of future, I think we have to embrace it because it's going to come. And that kind of disruption, that kind of reimagining what the care experience looks like is going to come. If it doesn't come from us, then it'll come from the outside. And we should really be the ones driving that as, clinicians and providers and those that really have the expertise to partner with patients. And so, I think I'm very optimistic about what the future holds. It's an exciting time. It's a wonderful time in prevention. The tools that we have now are really incredible. And I think the opportunity to really bring prevention to the population at scale is really in front of us now.
So let's spend our last couple of minutes talking about what we might want to do now while we're waiting for this wonderful future. Because I agree with you. I think people get nervous about the future. They don't like change. They complain about it. But the reality is, in the long run, everybody will get better care. Diseases will be identified much earlier, and it'll be much less expensive to take care of those diseases when they're caught early.
That's right.
And of course, the outcomes are going to be much better, even if that means some imaging item that tells people that you're developing atherosclerosis very early and you need more aggressive intervention. So what can we do today? What are you thinking about at Yale in terms of trying to move us to a situation where more people are achieving the guidelines, or maybe we're doing better at discerning who needs aggressive care and who doesn't?
Yeah, it's a great question. Maybe I'll sort of answer that in two parts. I think one part of what can be done now, the NLA for one, just as a wonderful organization that's been committed to the science, committed to patients, committed to a wide group of clinicians and providers that are committed to being kind of cardiovascular prevention and preventive partners with our patients, is doing very important work in this area. So for one, the LDL cholesterol simplified series will be out, and so of course I would encourage everyone to look at the guidelines. It's a terrific document. But then NLA has committed to distilling some of that to make things easy for that busy clinician. And so, stay tuned for kind of a new version of that document that I think is going to make things better and easier, more digestible for our clinical community. And then on the delivery side of things, we continue to be interested in thinking about how can the system innovate in this space? How do you bring imaging and imaging to the forefront to really partner with patients to engage and inform them in different ways around their risk. And I think one of the things that we've been very struck by is when a patient sees the presence of athero in their arteries with a calcium score or a coronary CTA. Maybe that coronary CTA has, plaque analysis, on it as well. But when a patient sees that with their own eyes, it connects them to that process in a very, very different way. It's not an abstraction. It's not a 10-year risk number. It's not a 30-year risk number. It's seeing what's happening inside of your own coronary arteries. I think that's an area that we are really keen to develop the science around of how do you use that technology to make decisions as clinicians, but also engage, educate, and empower patients in their own care around cardiovascular disease prevention.
Oh, I think that's a great analysis. The idea of now being able to tell, do you or don't you have atherosclerosis, as we were talking about at the beginning of our conversation, with something as low radiation as a calcium score.
Exactly.
And in our city, you can get a calcium score for $49. You don't have to go through insurance.
Yeah.
You can tell whether you have something or you don't. And I found early on when we started providing that the primary care doctors got nervous about what do I do with the result? I don't want to be responsible for this. But they have learned what that means.
That's right.
What we tell them is if you have any calcium, you've got atherosclerosis. So be aggressive. Treat them as the patient who's got atherosclerosis.
That's right.
If you have a 0, you don't say, you're good for you.
You're good. Yeah.
See me in 10 years. You say, especially if they have risk factors, right? You say, congratulations, your 10-year risk is very low. Now you have options. One option is to not go on therapy, but then we need to repeat the scan in 3 to 5 years. We still need to deal with your other risk factors, but maybe you don't need aggressive lipid lowering at this point. But the other option is, how'd you like to keep the arteries clean?
Exactly.
If you don't have any side effects, we can put you on a relatively inexpensive therapy with less likelihood of side effects and see how you do, but we won't tolerate any side effects. So giving those two options to patients with a 0 may help us make reasonable judgments for that third of people who, for whatever reason, don't get atherosclerosis. And of course, if they're 40, you might approach that differently than if they're 70 with a 0 score. And I think those are where we still need individual discussions with patients. So systems turn good doctors into great doctors, but one-on-one consideration of patients is still going to have to be part of the equation at some interval.
Yeah. Thanks so much, Alan. This was really great.
Thank you, Nihar. As always, your insights are fantastic, and I'm really excited that you discussed this during our strategic planning meetings at the NLA, and hopefully the NLA, as you alluded to, can get involved in bringing up some ideas on how we may do a better job for our patients in the long run.
Yeah. Thanks again.